Good morning, everyone. In fact, I'm delighted to come back to my alma mater and interact with you all people. And thanks to Amit and team for organizing this wonderful meeting and giving me this opportunity to interact with you. So, epidemiology, burden, and virology of HBV, I will be talking about. Sounds a little boring, but I will try to make it as interesting as possible for you all. I'm a extremely, fan of history. So let us start what happened with hepatitis B. So I will go retrograde. So the last major development in hepatitis B occurred in 2016 when you had this drug tenofovir alafenamide. That is one of the variants of already approved tenofovir drug. So if you go by this timeline from 1965 to 2016 onwards, almost 50 years have passed, 50, 60 years have passed when this journey started. And this journey started because of this man, Dr. Baruch Blumberg. And today is World Hepatitis Day, and we celebrate this World Hepatitis Day because on this day, this great man was born. So this Dr. Blumberg discovered this HBsAg way back in 1965, the HBV virus. And he discovered it while he was doing some experiments in cancer, finding some cure for cancer. And he collected a lot of blood samples throughout the world. And initially, this antigen was found in blood which was collected from Australian Aborigines. And that's why you also call it Australia antigen. From there, this name comes. Why is it called Australia antigen? Because initially, once he discovered it, it was found in those Australian original tribal people. So that's why you call it Australia antigen. Now, because I'll be talking about epidemiology, so this data is the latest data published by WHO in 2022. And just for the sake of ease, they have divided the whole world in various regions. And the Southeast Asia region, where India falls, is shown here. Can I have a pointer? No issue. So, so if you look overall, the global burden of hepatitis B virus infection, which is given here on the left side of the screen, and if you look at the global burden, then it is approximately 254 million. These are estimates only. 254 million people are infected with the hepatitis B virus. Now, out of this 254 million, if you look at the Southeast Asia region, that is this purple one where India lies, it is approximately 61 million. So out of 254 million, 61 million people reside in this area. That is approximately 1/4. And the second, this is the second biggest burden of these regions of total HBV infection in the world. The first one is the sub-Saharan Africa region, where again it is approximately 64 million. So sub-Saharan Africa and Southeast Asia, if you combine together, then almost you will see 50% of the world's HBV population resides in this area. So this is just to give you a glimpse of what is the quantum of disease that our region is facing right now. Also, we have tried to divide in various zones, into various zones, depending on the seroprevalence of HBV. If it is less than 2%, we say low, 2 to 4% low intermediate, 5 to 7% is high intermediate, and India falls in low intermediate zone, that is 2 to 4%. So the seroprevalence of hepatitis B virus in Indian population is 2 to 4%. Now, HBV infection, why are we concerned about? We are concerned if you talk to a patient, from patient's perspective, what is he concerned? He's not concerned about HBV virus. He says, is my liver going to fail? Am I going to develop cirrhosis? Am I going to develop hepatocellular carcinoma? If all these three outcomes are not there, let hepatitis be there, why I'm concerned. So the most important hard end pointer for HBV disease is cirrhosis. So if you talk of cirrhosis of various etiologies, let us see what is the role of HBV, how much HBV is involved in this all cirrhotic patients. So in Indian population, in Indian context, if you see, we fall around 20 to 30% of all cirrhotic populations can be attributed to HBV infection. Yes, these rates may vary from various region to region. Gradually, Thankfully, with all the government efforts, with availability of vaccine, with the initiation of early treatment, this percentage is gradually falling. And alcohol and non-alcoholic fatty liver disease is now becoming more important cause of cirrhosis. But giving the fact that it's a preventable and controllable disease, I would say, still this percentage needs to be brought down dramatically. So this was all about history. Let us say where the future lies. So these are the WHO estimates. What are the targets that they have set and where are we right now? So they started looking at new cases since 2015 onwards. And as shown in the slide, the above green light is the number of green line shows the number of new cases, and this is the number of deaths attributable to hepatitis B, the blue line. This green zone is the deviation that occurs around this median thing. So they have taken two time points once the data was available. First was in 2020, and then they looked at where are we in 2022. So they had certain targets that number of new infections should fall by this much. So we are on track if you see the number of new infections. If you see number of new infections, we are on track. But if you see the number of deaths that are attributable to hepatitis B, we are not following the trajectory. The number of deaths that are attributable to hepatitis B is increasing. Now, what could be the possible explanation of this? This means that the patients who are known hepatitis B, who are known to have HBV infection, possibly are not getting adequate treatment or they are not compliant to the treatment. That's why they are progressing very fast. And in spite of the diagnosis being made, the treatment cannot be offered. They are progressing to cirrhosis or liver cancer stage and then succumbing to death. So this is a very big challenge right now in front of all the policy making authorities. In spite of the availability of treatment, in spite of availability of the vaccine, the number of deaths that are attributable to hepatitis B is still increasing. Coming on to the country-wide data, this is again, I have taken it from WHO. And if you see, this is hepatitis B and C combined. This was published in 2022. And what it says is the total population, the total proportion of hepatitis B and C infected patients, how much patients are there in each country. Number one is China, approximately 27%, and we are at number two, that is 11.6%. If you look at hepatitis B, almost same ratio, will say 31% and 11.7%. That is 11.7% of total HBV patients throughout the world reside in our country. Now, coming within the country, let us see how is the distribution like. This is data from Ministry of Health and Family Welfare. So, this various color coding I have given. If talking of Uttar Pradesh specifically, we fall in this 0.5 to 1% prevalence, zero prevalence category. It is somehow extremely high in Andhra Pradesh, Telangana, and certain northeastern states. Now, within the country, people try to look at various factors. What determines in which subgroup of people hepatitis B is more common? So if you look at the gender, it is more common in males. Yes, it can be because of sampling bias. We all know most of the diseases in our country, you would see that males have more disease. Whether it is because preferentially males tend to go to the hospital more easily and even tend to ignore their illness, or it is the true data, we don't know. If you look at age-wise distribution, as age goes by, second, third, fourth, fifth decade, it is more common as you age. The reason is very simple, because as you age, you have more chances that you will have more pinpricks, more needling, and more surgeries. So it is more common in older age group. Rural and urban population, if you see, it is slightly more common in rural population. Again, pretty easy to understand. A lack of access of proper health care. Maybe the penetration of vaccination is not better in rural areas. There are several reasons for it. The most important thing is if you look at the caste-wise data, it clearly shows that in scheduled tribes it is extremely common. The reason that has been proposed is scheduled tribes usually they live in a very secluded kind of atmosphere, and usually it's a kind of a boundary based locality in which they live. That's why the virus tends to persist. Also, the healthcare access, the vaccine access is poor in these areas. In fact, if you see, the highest prevalence of HBV has been reported in some of the tribes from Andaman and Nicobar Islands, up to the tune of 70 to 80%, that it is that high. And if you look at wealth index, not hard to understand that people who are well to do, the prevalence is least in this. Now, this is the most interesting part. And because we are always interested as epidemiologists, from where does this infection occur? What is the main source? We all know that three main routes are there: through the sexual route, from mother to child transmission, and through pinpricks or needle pricks. So we try to look at what is the main reason. If you look at people who had high risk sexual intercourse in past 12 months, it was more common hepatitis B infection. If you look at ever received blood transfusion, now the history of blood transfusion specifically for hepatitis B, if you see, it is almost equal. For hepatitis C, the scenario may be different. And use of disposable syringe, mind you, it is the use of disposable syringe during last 1 year. Yes, if someone had an injection, even if it was disposable syringe, the chances of acquiring HBV infection is high. That puts question about how meticulously the process has been followed. Now, coming briefly on the virology part of hepatitis B, just to keep things simple, this is a diagrammatic representation of hepatitis B virus. It is around 42 nanometers in diameter. Basically, at the center of this virus is HBV relaxed circular DNA, the DNA material, the DNA of HBV. Now it has two layers above this HBV DNA. The first one is the capsid. It's made up of a protein, and we call it the capsid. And above this is the envelope, the surface protein. So this envelope is made up of, this outermost layer is made up of three kinds of proteins, the L, M, and S, out of which this S protein is most important, the hepatitis B surface antigen. And why is it important? Because this is the antigen which we use for diagnosis. The antibodies that are formed by our body against this antigen are protective in nature. The antibodies formed against the capsid antigen and other forms of antigen are not protective. They don't protect us from the infection, but the antibodies against surface antigen are protective. Plus, some of the receptors which are present on this envelope help in attaching the virus with the hepatocyte, through which it gains entry into the liver cells. So for researchers, it has always been a very active area of research where they are trying to target it with various drugs so that the virus could not enter our body. If you look at the genome of the hepatitis B, there are four main genes in this whole hepatitis B DNA. I will just enumerate and read out the functions of them. The S gene, the outermost, which is shown here, it has got three parts: the pre-S1, pre-S2, and S. It encodes for the surface envelope protein. These protein particles are non-infectious subviral HBsAg particles. What I mean, I would explain it in the next slide. HBsAg promotes T cell exhaustion, and this is the protein which is encoded by S gene, which is used for immune and diagnostic escape mutants. Escape mutants, what are escape mutants? Escape mutants are certain mutations occur in this gene where HBsAg, by routine tests that we use, can be negative in spite of patient being infected with hepatitis B virus. So where the suspicion is strong, mostly in dialysis patients, if you have acute hepatitis, viral markers are negative, we often go for the DNA and RNA based test for hepatitis B and C. At times you will find that HBsAg can be negative and DNA can be positive, but those are rare situations. It can happen because of mutations in this gene. The second is the polymerase gene, which has got 4 domains and 3 enzymatic activities. It encodes for protein priming functions. It encodes for RNA dependent DNA polymerase and DNA dependent DNA polymerase, and another enzyme, that is ribonuclease H activity. Mutations in this gene are associated with various drug resistance. Then you have the gene C, that is hepatitis B, that encodes for the core antigen. And then you have hepatitis B X protein, which has been proposed to have some role in oncogenesis, that is hepatocellular carcinoma induced by HBV. A brief description, since I have to talk of virology, a brief description about how the virus enters the cells. This is the hepatocyte, and within this hepatocyte, the virus enters by attaching to a membrane receptor called NTCP, sodium taurocholate coenzyme protein. And through this receptor, the virus enters the hepatocyte. And once it enters, its DNA comes out within the nucleus. It combines with the host genome mechanism and starts secreting several proteins, which include the core antigen, HBC, the polymerase enzyme, the surface antigen, the HBX proteins, and all these proteins that are formed and the DNA that is formed are reassembled. They are reassembled and then secreted as full grown adult viruses. In blood, these have been initially described as Dane particle. However, many a times this whole assembly may fail. So the cells may secrete only proteins, that is E antigen, or at times it can be only surface antigens only without any genome within it. So these are non-infective part which can be seen in blood without this whole Dane particle. So this is just a brief about life cycle of hepatitis B. Talking about once the virus enters your body, what happens? A lot many factors come into play, including the host immune response, at what age it has entered, in what quantum it has entered, and the host immune status. So classical natural history of hepatitis B says that if it is acquired early in life, somehow your own body assumes that this is your own antigen, and it does not mount an immune inflammatory response against this virus. So we call it immune tolerant phase. Immune tolerant phase means that the immune system is tolerating that antigen present in your body. They are not mounting an immune response. After certain time, for some unknown factors, the virus replicates actively in this stage, and gradually this seroconversion occurs. The E antigen seroconversion becomes positive or negative. Rarely a mutation occurs in this E antigen encoding gene, where pre-core mutation we say the E antigen may become negative. So this cycle of viral replication keeps on going. In between, once the childhood phase is over, patient may develop immune system may develop an immune response against this virus, which leads to inflammation within the liver. Inflammation leads to fibrosis, and this may lead to cirrhosis. I would skip this slide. I think my next speaker is going to talk of various antigens and antibodies serological tests. Just my last slide. How do we understand HBV markers? If you see, these are the tests which are available with us. Hepatitis B surface antigen, hepatitis B C antigen, that is core antigen. Total I have written because you have IgM anti-HBC as well as IgG. So IgM separately can be ordered, IgG can be separately ordered, or you can look at the total anti-HBC core antigen. Total means combination of IgM and IgG, or you have anti-HBS antibodies. So various permutation and combinations we have listed here. Let us take one by one. If everything is negative, obviously the person was never exposed to hepatitis B. Now, if someone has got positive and anti-HBS is positive, so this means antibodies against surface antigen are there, and antibodies against core antigen is also there. So because antigen against core anti-HBC antibodies are present, this means patient had past infection with hepatitis B, which recovered fully, and now patient is anti-HBS positive. Anti-HBS positivity means mostly the virus has been eradicated from one's body. Now imagine, compare this situation with a person who has been immunized with it. Now in immunized person, what happens is, because it's an artificial immunity, given by the extrinsic vaccine, not by the original infection, the hepatitis B core antigen would be absent. So if anti-HBs is present, either it has been acquired through vaccine or it has been acquired through natural infection, and this can be differentiated using this hepatitis B core antibody. Similarly, I have listed here various other permutations and combinations. IgM anti-HBC we use often to differentiate if a patient comes with deep jaundice, acute hepatitis like picture. We are often confused whether it's a chronic hepatitis which has got suddenly activated or it is an acute infection. At times, IgM anti-HBC helps in differentiating, because if IgM anti-HBC is positive, most likely we are dealing with acute HBV infection. And this question is very important because acute HBV infection has got more or less a benign course. The body eradicates this virus within 6 months. With this, I would like to end here, and with this last slide. Today is the World Hepatitis Day, and this year the slogan has been "It's time for action." So it's time for action against hepatitis B. Let's hope we will follow the WHO guidelines and their targets of reducing new infections and deaths due to hepatitis B. Thank you.